Ankle fractures is something we deal with on a daily basis, almost daily basis, probably weekly at the very least. They come in all different varieties. John Kwon is going to talk about, moderate the session about how we deal with this in the athlete. I want to thank Osseo, the sponsor for this session. John, it's all yours.
Thank you. I'd like to thank Selene and the Parekh Family Foundation for giving us the opportunity to talk about ankle fractures, and also like to thank Osseo for their support. Quickly, I'm joined by my partners, Dr. Daniel Guss, who is our fellowship director and a world expert on syndesmosis. Lorena Pineda, who has just joined us and, quote me now, is a rising all-star in our field. Chris Miller, who's the chief of foot and ankle at Beth Israel Deaconess Medical Center and really an emerging leader in MIS, and he's going to show us some MIS techniques for ankle fractures. And Joe Park, who is the chief of foot and ankle at UVA, who takes care of a lot of high-level collegiate and pro athletes. So he'll give us his perspective on that patient population as well. So without further ado, Dr. Pineda, why don't you go ahead and share your screen and go ahead.
Okay, so first of all, I want to thank Selene and the whole Parekh Foundation as well for giving us this opportunity to talk about such a common injury that we all face on a daily basis. So the first case, this is a 19-year-old female college softball player who had a mechanical fall and came to clinic with an ankle pain, and inability to bear weight. Physical exam, nothing out of usual, moderate swelling and slight ecchymosis. These are her non-weathering x-rays. And this is the CT, which we're gonna see a trimalleolar ankle fracture. Sorry, is everybody seeing my presentation now? I think it was
we can see it now. If you want to just go to, you just have to go to slideshow. There you go, perfect.
Okay, so as I was telling you, 19 years old, this is the weight-bearing, this is the non-weight-bearing x-rays that we got with the patient when she came to clinic. Now, this is the CT. As we're gonna see here, the trimalleolar ankle fracture that initially in the x-ray didn't see like very comminuted, but we will see here. She got the posterior malleolus fracture with some comminution and the medial malleolus as well. So we took her to the operating room. We started with the lateral approach. We, through the fibular fracture, which was an oblique simple fracture, we accessed the posterior malleolus. We decided to also do the approach over the medial side to have complete exposure with both sides to gain reduction. Some of the fragments in the posterior malleolus we were able to reduce it. Unfortunately, some of them were very small that they were not suitable for reduction and fixation. After that, we, under direct visualization, we reduced the posterior malleolus. We fixed it temporarily with some K-wires, and then we did the reduction and fixation of the fibula. Then we went to the medial malleolus. We reduced and fixate the medial malleolus, and finally we put the screws AP over the K-wires that were holding the posterior malleolus fracture. As you can see here, there's a small plate over the anterior aspect of the medial malleolus that was necessary given that the fracture over the medial side had it was like biplanar. So it wasn't getting the entire fixation just with the anti-blade plate. She came to clinic at 2 weeks. At that time, she got some blisters on the posterior aspect. So we decided to, instead of transition her over a tall boot, we put her in a bivalve cast. So she can be removed days one for range of motion and during physical therapy without any weight bearing. She started physical therapy at week 3, just for range of motion, and then finally came back at 6 weeks after surgery. These are her x-rays. At that time, she was transitioned to a 12 boot, and we start progressing weight bearing. We start with 25 pounds, and then we gradually progress every 3 to 5 days until she gets full weight bearing. These are her x-rays at 12 weeks. At this time, the patient was walking, full weight bearing, no issues. She developed a little bit sensitivity over the sural nerve that eventually at the 4 or 5 month mark, she got better. She was able, like our protocol, this is what we usually use for trimalleolar and bimalleolar ankle fractures. We try to be a little bit more aggressive with athletes and young patients, but usually we use a splint. I know some people use a boot for the first 2 weeks. Physical therapy starts at week 2 or 3, just for range of motion, and we start progressing with varying between 4 and 6 weeks. Of course, depends on the pattern of fracture and the comminution. Low impact activities as swimming or Pilates or yoga starts at 12 weeks, and high impact activities as jogging and progressively running at 16 weeks. Usually, if they are involved in contact sports, they will return at 20 weeks. So, what are the goals in general for these patients? And for every patient, independent of their athletes or not, functional and pain-free ankle is our goal when we have a patient with an ankle fracture. Now, when we have an athlete, we have additional goals, and it's a return to pre-injury sport activity and minimize that time that they take off while they get the injury and they come back to competition. And looking at the literature a little bit of how we can treat them, how we can minimize this time to return to play and get them to the level that they were before, I found that there's not a lot of evidence. And this is one study that it was just done in patients that were athletes and include only 27 patients. But to the point, they were only included athletes. They have a final follow-up of 2.4 years. And they were a little bit more aggressive for their progressing. They start protected weight bearing and range of motion at week 1. They also start with low impact activities as stationary bike after 1 week after surgery. And they keep the patient in the boot for 2 weeks or 4 to 6 weeks, depends on the type of fractures. They have about 10 bimalleolar ankle fractures, 16 that were isolated fibula fractures, and then the combination of pilon fracture with syndesmotic injuries for others. The return to sports of this case series is significantly high. 26 out of 27 patients came back to return to play. So that kind of like tell us that we can be even more aggressive with it. There is the management of unstable ankle fractures, and this is a review paper which I wanted to bring these as because how the differences between the patterns, if we have just an isolated ankle fractures or if we have a bimalleolar or syndesmotic injury. As we can see here, in terms of weight bearing and competition, the times double. When patients have bimalleolar ankle fractures, syndesmotic injuries, the time to return to play increases even 3 times. Now, how often they return to play? So when we look at data from original papers that include mainly patients that have ankle fractures related to the sport activity, the return to play is significantly high. Even in the worst case is 87%, which I think in general is a very good number. And of course, when we see and we compare between non-operative to operative treatment, those that have non-operative treatment usually return to play in 100% and more than 90%. I think this is also related to the type of fracture that is usually, if we're not doing surgery, is a stable fracture more than what we're doing in terms of how we're treating them. The return to play changes a little bit, and some articles like this one, when they talk about mainly isolated fibula fractures, the return to play, it's about 17 weeks. This is a systematic review when they were looking at patients with ankle fracture related to sports, and 2 negative factors that they saw that it was associated between patients that have ankle fractures and return to sports activity were female gender and associated syndesmotic injury. So when we have these two, usually they found, and based on the studies, that the patients usually don't do as well if they don't have a syndesmotic injury or comparing to males. So in conclusion, we have a wide variety of results. The evidence in what we should be doing after we treat these patients and how we can expedite the recovery is poor, and there's no clear guidelines. So when we don't have a level 1 evidence, what do we have to do? And that's what I wanted to bring the big questions so we can discuss and we can see based on everybody's experience, what do you do in terms of weight bearing? Is there any difference in terms of patterns? What are the things that make change your protocol? If you have a posterior malleolus fracture, if you fix it or not, that will change the way that you start weight bearing and how aggressive you are with your recovery. And in your experience, how long does your patients return to sport? Thank you.
Lorena, thank you. Excellent presentation. So Joe, Chris, and Daniel, why don't we start with that first one? What about, how do you think about weight bearing and time to weight bearing, especially in the athletic population? And, certainly different considerations if the syndesmosis is in or out or deltoid, but Joe, you want to start?
Yeah, sure. I'm a little more conservative than some of my colleagues around the country regarding weight bearing. I do think that early motion is really critical. So I try to let them start moving and get into a boot at 2 weeks, but I do try to hold them off from weight bearing at least 4 weeks, sometimes 6, depending on, like you said, if there's a syndesmotic injury or a deltoid injury that I've repaired. But what I've found is if I can trust my repair, I start them moving very quickly. And I think that seems to speed their recovery back to the field.
Yeah, I think there've been some pretty good studies coming out recently saying that early weight bearing after ankle fractures is relatively safe and can improve outcomes because I think you get them moving and walking sooner, and it hasn't decreased the rate of union significantly. Now, the one you showed, Lorena, really with that posterior comminution, I'd be probably a little bit more conservative like you were and keep them off. Especially with sort of the screw fixation you had there. But, I'm going to show in the next case one where I let the guys start walking on it almost right away. So I think you can, in the right setting, you just have to spend a lot more time counseling the patient on like, what does weight bearing as tolerated mean? Which I think is very different from just allowing full weight bearing. Yeah, I have that conversation, which can take a little while with the patient to understand what's allowed and what's not.
Yeah, what I would agree. I mean, I think the problem with these studies about weight bearing is that there's a huge variety of what an ankle fracture means. And so we're often comparing apples to oranges. I separate very much if there's plafond involvement versus malleolar involvement, right? Is it the wall of the house or the roof? Once it's the roof, I slow them down. I similarly get them moving once the wounds heal. But the second there's plafond involvement, but also syndesmotic involvement. When you think about ligamentous healing is different than bony healing. And when you weight bear with a syndesmotic injury, you're creating these almost these hoop stretches that are trying, right? As the talus is driven upwards, it's wider inferiorly than superiorly. It's trying to drive that syndesmosis apart. That'll also drive me to slow people down. But movement is as early as possible. And for me, that's at 2 weeks when the wounds heal.
Awesome. Great, guys. All right, Chris, you want to go ahead and share your screen?
Okay. Thank you. If you can't see my screen, just let me know, but otherwise I'll get started here. So I'm going to talk about sort of minimally invasive approach to an ankle fracture here. My name is Chris Miller. So these are my disclosures here. So my case is a 33-year-old healthy cardiologist, foreign trained, and he's actually in the U.S. military and hoping to retrain in the United States. So he's quite active, and he was a former sort of collegiate level soccer player. He plays in the club soccer league in the area, but they're all sort of former college varsity athletes and semi-pro people. So it's not just like a weekend league. They really take it quite seriously. And complicating things additionally, he's starting a medical internship to retrain the US in 6 weeks from when I saw him. And so, he was very concerned about his military and immigration status, which put some additional pressure on him to sort of make sure he started on time. I don't know exactly how valid that was, but it was something he was very sort of perseverative on, and really wanted to make sure he could start his internship. So these were his injuries here, which is a much simpler fracture pattern than what Dr. Pineda just showed. Certainly a lot of options. I think this is bread and butter for an ankle fracture and, small medial malavulsion. So we know the deltoid's involved and some displacement and a lot of different good options for doing this. But given his sort of military, his activity, and his commitment to start as an intern in 6 weeks, a month and a half, I wanted to find something that might give him a faster recovery and accelerate the rehab. So, I was going to pause here and ask what the panel would do, but I'm going to actually continue on, and maybe we can address this on the end. You guys can criticize what I did as we go. So my surgical plan was I was going to start with ankle arthroscopy. I was planning to repair his deltoid ligament with the scope and then use a fibular nail. So this was his stress view here. And now when I say that a Weber B is easier to control with a nail, I don't mean compared to a plate. I really mean compared to like a higher level fibular injury, like a Weber C or higher. But I like that this allows me a more percutaneous approach. Certainly I see anecdotally less pain in my MIS patients across the board, and there's in general less wound issues. So I like that as a concept for him in terms of being able to get him moving quicker. And then the arthroscopy allows me to identify any sort of concomitant pathology. And as I've gotten into more of the ligament repairs, I can then do the work to repair ligaments as well. So that has really driven me to do more ankle scopes in the setting of fracture. I like this study up here, the top one, which was a propensity matched analysis. So they were looking at 4-year outcomes in a arthroscopic assisted versus no arthroscopy ORAF group. And they found that the OMAS scores were higher in the arthroscopy groups, and as was the FAM sports scores at 4 years. Now, I will put a little plug in for Dr. Kwon and somewhat for myself for the lower systematic review. We didn't have, it was about the same time, so we didn't know about this top one when we wrote that, but it summarized some of the data there as well. And then when it comes to the deltoid, and I give Dr. Acevedo and Dr. Mangone a lot of credit here, because some of them have really pioneered using the scope and repairing ligaments and doing more than just debridement in the ankle. But we know that 40% of unstable fractures involve the deltoid. And Dr. Guss and his team have shown that the deltoid in the setting of syndesmotic disruption has a significant stabilizing effect even on the syndesmosis. So if we can repair it, then we can repair all sides of the injury, both the medial injury and the lateral, and maybe prevent some of this post-op medial instability that we sometimes see in higher level activity. This is just some pictures from Dr. Acevedo's paper here showing the technique, but passing the sutures about 1.5 centimeters distal and through this medial safe zone, and you're placing anchors into the anterior aspect of the medial malleolus here. And just some pictures of what it looks like clinically on the side there. Not a lot of outcome data that I've been able to find in the setting of fracture. Dr. Vega and the group in Barcelona have really looked at this in terms of medial ankle instability and global ankle instability patients. And so this was their case series of 13 patients, all of whom had improved symptoms, and one person had some suture knot tenderness at the medial side. So these were the intra-op photos from my case. You can see here, we're just marking out where everything is, reducing it percutaneously. So just 2 small poke, and then the sort of standard reduction maneuver with the clamp, getting our start point, and then opening reamer, proximal reamer here, and then placing the fibular nail. And you can see we're just measuring the depth with that guide wire on the side. And so this is the final initial nail construct. This particular one has some proximal fixation with the tines that open up to help prevent proximal migration, which I think is an advantage of this nail. Other nails do have it in other fashions as well. And then the final construct. So here, in this case, I started with the scope. I actually placed the anchor for the deltoid first, past it, but I didn't tie it down until the end. So I did the nail, we did the syndesmos, the tightrope, and then at the very end, once we were happy, we still had the medial ankle instability. So I tied that down to complete the repair. And then this was some pictures out of a study that I think Dr. Parekh wrote up, looking at the incisions that we have after a typical fibular nail case. So my post-op course for this particular individual, and this is not emblematic of all my practice, but I did allow immediate weight bearing as tolerated in a post-op boot. He was transitioning to a lace-up ankle brace and starting PT at the 2-week time. And by 6 weeks, had no pain. He had started jogging, and he had to do a military fit test, 2-mile run. These were his pre and post-op scores. So he only lost about 20 seconds during the recovery time. And for him, he was able to start his intern year on time. But he felt more comfortable in the boot getting around the hospital. In terms of the fibular nail, as I've dug into it a little bit, I've seen some pretty good results, and we know biomechanically it's quite favorable. Minimal learning curve if you're experienced with sort of modern orthopedic techniques, which we all are. You can pick this up pretty quickly. And in general, we're seeing less wound and infections compared to plate fixation, and similar or sometimes better outcomes in the randomized controlled trials that are out there. This was just a very recent meta-analysis. It's still in press, but you can find it online, which showed lower rates of infection and complications in the nail group. So final thoughts, I often talk about MIS as being a philosophy of care as opposed to a single type of surgery. And here we're utilizing our arthroscopy skills, percutaneous fracture fixation techniques, arthroscopic ligament repairs, and creating what I consider to be a synergy of techniques that help improve our patient outcomes here and hopefully decrease the risk. So thank you very much.
Hey, Chris, I just want to comment. That's a great talk. The MIS, a lot of people, are so, it's not the AO technique. And so a lot of people are concerned about using MIS, and they'll use it in the high risk patients to begin with. Mm-hmm. But you quickly realize the benefit of it, and it has become the standard of care in my practice. I think the fractures heal faster because you're not stripping the periosteum. It's smaller incisions. The endosteal blood supply is preserved as well, and you're grafting it because you're tapping it. Yep. So it's dramatically different as a recovery when you go down this path. Yeah. So thanks for bringing this about.
Yeah. And they have, for me, my patients that have done this have had much less pain. I do think that you have to get good at the fracture fixation. And here I did it early. So I was able to get it with just 2 little pokes with the jig, but there are a lot of techniques out there to get the reduction. And I think that the key point is you can't sacrifice reduction just for MIS. So you're not trying to do MIS surgery, but a bad surgery. You still need to get your principles, which is reduction before fixation. And sometimes that necessitates a small open to put a more standard clamp on.
Hey, Chris, really neat case. His 2-mile time is just about my 1-mile time, but
Mine too.
Yeah, and so admittedly, I have very little experience with intramedullary fixation for fibular fractures, aside from kind of perking a long screw for a transverse fracture or whatnot. Can you tell us some technique pearls for using the intramedullary nail?
Yeah, I think the biggest thing I can say is just patience. Um, you know, if you're doing a femoral nail or tibial nail, and the start point's not right, you're completely off. And if you're doing a straight femoral nail, like, you gotta get the piriformis to start point. And so that's often the hardest part of this. And now it is, pretty, it's right below the skin, so it should be easy to feel, but it's surprisingly sometimes getting it right. It wants to slip a little bit, the K-wire. Just take your time. And if it, just because it's MIS doesn't mean it's going to be faster. And I think that's the other point to make. Like, sometimes these cases may take you a little bit longer, especially early in the learning curve. But once you get the fracture reduced, and it goes pretty smoothly once you can get the guide wire in the right spot, and just make sure that you're not too posterior starting with the guide wire, because I wouldn't want to rub on the perineals back there either.
Yeah, and Chris, can you just talk briefly about your learning curve with the arthroscopic deltoid repair? I know you've published on some things, and I know from watching some of your cases that you started on the lateral side with the lateral ligaments. But can you talk a little bit about that? Because I find that fascinating about doing the deltoid that way.
Yeah, I actually just did it yesterday in a case, and it's, if you've done the arthroscopic rostrum on the lateral side, it's almost the same technique on the medial side, but because the deep deltoid is hard to grab, a lot of times I use a microsuture lasso, and what I find is much easier to sort of start, and I do an outside in technique where I drive the lasso through the ligaments, and then I try and come up right in the medial part, like right next to the medial talus, to grab a little bit of that deep deltoid as well. But you just need to really know the anatomy and feel confident. And so I spend a lot of time, like, if I can't feel the posterior tib, I do a little mini open to do this. But I think it's just getting comfortable with your sort of trajectory. And if you're doing scopes, like, it's all about triangulating the anatomy. But all of these things that I've done, I've practiced multiple times in the lab before I'd ever bring it to the clinical setting. And that's by far the most important thing when you're doing these minimal invasive techniques.
All right, Dr. Miller, thank you. Why don't we move on to Dr. Guss's case?
And so first and foremost, thank you to everyone for the opportunity to present. Those are two hard talks to follow. I'd also like to thank the Parekh Foundation and all the industry sponsors who make this possible. And so these are my personal disclosures, none explicitly related to this talk. And so this is a 20-year-old female, a local collegiate soccer player. She's a striker, and she was in the middle of a game when she isn't sure about the exact injury mechanism. She only describes that her ankle was, quote, taken out, and found herself unable to walk. And so, as you can see, these are partial weight-bearing films, and she's got this lateral malleolus fracture. The medial clear space looks symmetric, and I find that sometimes it's the simplest stuff that we face that's the hardest, because you look at this, and if you think about the traditional reasons we fix ankle fractures, we're not actually talking much about the fibula. What we actually tend to focus on is the loss of the relationship between the tibia and the talus, right? It's not the fracture, it's the instability of the relationship between the bones that we address. But you're looking at this picture and you're saying, okay, we talk a lot about the medial clear space. We don't talk a lot about the lateral clear space. Clearly the medial clear space looks symmetric on this X-ray. But you're staring at that lateral gutter in a young 20-year-old elite athlete. And you start asking yourself, do I move away from the traditional teaching at some point? Is there a threshold where I should be thinking about fixing Weber B fractures, irrespective of what's going on with the deltoid? And The reason I've always thought about this is one, you look at this and as orthopedic surgeons, we want to make things anatomic, but the other fact is we talk about the deltoid, we talk about the syndesmosis, but if the fibula didn't matter, then why does it have cartilage on its medial aspect? Very little in the body is designed or evolved to be without purpose. And so if it didn't have cartilage, why is it designed to then abut the lateral part of the talus, and does that make a difference? And I've always wondered this. And so, you know, sometimes the simple can be harder than the complex, right? Some of the prior fractures, when you see medial clear space, widening the surgery may be more, you know, complicated, but the decision making is much easier. And what made me truly think about this is actually not studies that we did, or what evolved my thinking about it, not studies that we did specifically about isolated Weber B fractures. It came from a lot of our syndesmotic research that started with arthroscopy and then evolved to weight-bearing CT, because ultimately things look different when you're looking at them under physiologic load, but they also start looking differently when you start looking them at more than one dimension. When you think about what medial clear space is, it's a one-dimensional measurement. And so we started with the syndesmotic instability and showed that weight-bearing CT can be a useful tool in diagnosing this when you're looking at the volume of not the medial clear space, but of the distal tibiofibular articulation. But interestingly, then we evolved to say, hey, what happens if someone has a fracture? Does that change my ability to use weight-bearing CT to diagnose subtle syndesmotic instability? And what came out of this study is we were looking at the data, and what I noticed is even in our controls. So in this study, we specifically complained patients with Weber B fractures that had syndesmotic instability intraoperatively and those that did not, and found that weight-bearing CT was able to distinguish the two. But what we noticed as a team is that if you look at the medial clear space volume, that it was elevated, even in those patients with Weber Bs that did not have syndesmotic instability. And it's unclear why. And that made us think maybe it is due to this buttressing effect of the fibula. And so we designed a study. What we did now is to look not at the syndesmosis using Weber-bearing CT, but at the medial clear space. And I have to thank Rohan Behmani, who lent me these slides from our last AOFAS meeting where we submitted an abstract. And we looked at patients with unilateral Weber B ankle fractures who underwent bilateral weight-bearing CT and compared them to a slew of patients who underwent similar weight-bearing CTs, but for other things like Lisfranc instability. And we looked at various measurements, but the key criteria is every single one of these patients had a symmetric medial clear space on weight-bearing radiographs. And we measured a slew of things, including medial clear space volume. And so now what we're talking about is moving away from one-dimensional measurements, distance, moving away from two-dimensional measurements, area, to three-dimensional measurements. But we also looked at the others, distance and area. And this is a busy slide. I'm only going to draw you to one. The only thing, these are what we would traditionally have called stable Weber Bs. They have a symmetric medial clear space. If you look at the volume of the medial clear space, it's elevated. Of the medial gutter, it's elevated. But on the flip side, if you look at things like, and it was not in the controls. So those without a Weber B fracture, i.e. a Lisfranc, it was not elevated compared to the contralateral side. And so what we did is we then created a sensitivity and specificity curve and found that what optimizes it is if there's fibular displacement of more than 2.3 millimeters. And so the conclusion is weight-bearing, on weight-bearing CT, the medial clear space volume does increase significantly if you have a Weber B fracture, even if the initial distance is symmetric on radiographs. And 2.3 millimeters is about a threshold that optimizes sensitivity and specificity for this. And this isn't a clinical conclusion, it's an imaging conclusion. And so future clinical studies are necessary to understand what this means in the long run. When you do start getting these asymmetries, right? It's not just about tension in the deltoid, the fibula does buttress. And so coming back to our original patient, if you look at this measurement, it's about 4 millimeters of fibular displacement. And so, you know, we had a long conversation. I was very honest with her about the gray zone in which we're operating, that this isn't the traditional reason. we take someone to the operating room, and so we performed fixation of the lateral malleolus. What I do is I put in my my lag screws, and then I stress the syndesmosis. And if you're not having to put in any syndesmotic fixation, this allows you to use very small. This is a 2.4 millimeter plate with 2.4 and 2.7 millimeter screws. When you think about the traditional 3.5 millimeter fixation that we use in the fibula, that's almost a historic precedent. It's counterintuitive to me that we use the same size screws in the fibula that we use in the femur. And this is just a clinical image of this plate in anticipation of this talk. And this surgery was just 2 weeks ago. So we're going to start advancing her motion, as soon as I see her in follow-up, and be pretty proactive with her weight bearing. But I thank you all, and I welcome the panel's thoughts.
Daniel, thank you. That's, one thing I like about these cases is that these are just kind of bread and butter stuff that we see every day, right? And it really makes us think about kind of what we're doing. So yeah, certainly, I think that's really interesting. I think maybe David Thordarson had started this years ago about fibular displacement and how this kind of affects the ankle. But certainly I want to know the panelists' thoughts. So we're talking about a young athlete, and you have relatively displaced fibula and maybe increased lateral clear space. But however you go on to diagnose medial instability, whether you like to do a gravity stress or weight-bearing stress, that looks okay. So how do you deal with this patient who has an apparent stable mortise but a widely displaced fibula? Hey, Lorena, we'll start with you and we'll go around.
Sure. So one of the things that they kind of like it relates to what Daniel was mentioning is a few years ago paper talking about the outcomes of patients with fibular fractures and how the degree of displacement that affect these long term. They actually talk more about the displacement in the sagittal plane more than the coronal plane. We have been focused so much in the coronal plane, and they talk about the displacement more than 2 millimeters in the sagittal plane. It talks about instability of the fracture, even if we don't see in the X-rays a clear opening or gap of the medial clear space. So I will say, especially for young patients or healthy patients in general that are very active, that's probably my breaking point. If I see any displacement, especially in the lateral view of more than 2 millimeters, I tend to be more aggressive and treat them surgically.
John, if I could speak up, I think for a lot of us, what our experiences are and how we treat our patients is related to how other patients have done and the thousands of patients we've treated. And so if you treat someone for a non-operative fibula fracture, as we all know, we're reshooting X-rays, weight-bearing X-rays. And I would argue that it is far more complicated to treat them non-operatively almost than in an elite athlete where I want to start them moving. And in contrast to what I said earlier, for an isolated displaced fibula in an athlete, if I fix it, as soon as that wound is healed, again, I start motion, but I let those guys weight bear. If I stress the deltoid at the time of surgery very aggressively, and if I know that their medial structures are intact, that's a patient that I want to try to get back as quickly as possible. And I think that's almost impossible to do with a non-operative treatment. And so for an athlete who has a time frame, I think that's a patient you can even get back in season, at the 6 to 8 week point, assuming everything heals perfectly. But I think that's a big determinant. I think non-operatively, they're still hurting and swelling by 3 months, even 6 months I've seen in my practice.
Yeah, I think like you're saying, that's a tough, it's a tough decision making. And so I send all those over to Dan Guss to take care of for me. But no, kidding aside, I like that in this population. I think that you can justify doing it for what Dr. Park was saying. Just a clarifying question for you, Dan. You said 4 millimeters of displacement. Are you looking at that on the AP mortis view, or is it on the CT? Like how are you defining in what plane the displacement has to be so that when I look at it, I know what to do.
And no, it's a great question. And that's where I just gave most of these Weber B fractures we're not getting CTs on, right? That's the reality. And so only when we think about something idiosyncratic or potentially operative. And so you're right, the displacement, and as Lorena brought up, sagittal plane as well, ideally. And don't forget, there's coronal, there's sagittal, there's also rotational. That's even harder to measure. And then you truly need a CT. And so my answer to that is we're learning. I think the most intuitive is what we saw on the mortise view. I think that's the one that we look at the most. I think, to Lorena's point, we should be looking as well at the sagittal, because there's often a posterior translation. And don't forget about shortening too. That's another one we don't talk about, given the obliquity of the fractures, right? When you think about the maneuver to reduction. And so the answer to that is we're learning and we don't really know. But if you see it in any plane, right, that's going to be the minimum amount in addition to the others. And so I'm generally measuring them at least in the coronal plane as well as the sagittal plane. But this is just a very recent study, right? This medial clear space volume we just presented at the winter meeting of the AOFAS in February. And so this is data that we're learning. But what I'm thinking about is not even the season. When you think about a 20-year-old and the hopefully, 80 years of life expectancy, what does it mean? Our long-term follow-up is not lifelong. And so permanent loss of the fibular buttress over the course of decades, 25 years, 50 years, relying entirely on the deltoid to act under tension, we generally, in a lot of areas of orthopedics, think that soft tissues will fail without bony support over time. And so that's what made us start thinking about this, and we need clinical studies, and we need others, who are on this panel and those who are listening to help guide this, because there's something we're not picking up on, perhaps because we just don't have, lifelong follow-up.
Yeah, Daniel, I'm really excited to see this come out in the literature. Our entire treatment of ankle fractures is predicated on 1 to 2 millimeters of displacement, right? And as we're seeing, you might not be able to pick that up on x-ray. So what we think is anatomic may actually not be anatomic. And so, Bonnie Chin, who's at Columbia, and our research group has looked at this for stable Weber Bs, and we got bilateral CT scan. And now, granted, using 2-dimensional measurements, we found that there was a 0.7 millimeter difference in the medial clear space. And so, I'm looking forward to your study coming out using the more sensitive volumetric analysis. And maybe we're going to change thought that these may not be as anatomic as they should be.
Yeah, and that's where, interestingly, area did not come up as significant in this study. You really had to start relying on diagnosing. And this is to your point about philosophy of MIS, Chris. There's a philosophy of diagnosis, right? We keep diagnosing 3-dimensional problems with 1-dimensional or 2-dimensional rulers.
And actually, for the group too, I think one thing we often don't talk about with ankle fractures is the foot alignment. So a lot of the people I have to take care of, like let's say my offensive lineman who weighs 320 and they have already an 8-degree hindfoot valgus alignment, a short fibula, I think that's dooming the deltoid long-term. So I think that's the other concept that, check the contralateral side and all those things. But I think foot alignment determines a lot of that as well.
Awesome. Joe, you want to go ahead and share your screen?
Absolutely. Oh, sorry, John. Let's see. Oh, shoot. Hey, John, I'm really sorry. It says I couldn't share my screen. Let me see. Oh, there we go.
Yeah, we can see it, Joe.
Okay, great. Sorry about that. All right, I'm going to go quickly. I know our time is somewhat limited. So this is one of my tougher cases I've seen. No relative or important conflicts of interest. There's a 21-year-old cornerback. He sustained an ankle fracture dislocation during a nationally televised game at Miami. He was reduced on the field and splinted. Of course, he's a preseason All-American, projected first-round NFL draft pick. which of course just adds to the stress of this case. Here is his x-ray taken at the field. You can see a high Weber C fracture, and seeing the video, which still to this day makes me nauseous, his ankle completely dislocated on the field. And so diagnosis, distal fibular fracture Weber C with syndesmotic disruption. I think, as we all know, by definition, a deltoid ligament rupture. So the plan was definitely fix the fibula. I wasn't sure about the scope. I'll talk about that in a little bit. Syndesmotic screws, which is what our trauma partners would almost certainly recommend, versus flexible fixation. And then what about the deltoid? So just going through quickly, arthroscopy, I think in these high-level NFL caliber players, I think that answer is pretty clear. I think in a displaced fracture where you're worried about chondral injury, I think you should scope the ankle. This was a Hinterman study. He looked at almost 300 ankle fractures, and 80% of them had articular lesions. This was highest in this exact patient, Weber C pronation external rotation, as well as with syndesmotic disruption. And I would argue, if your player is going to the NFL draft or the combines, the first thing they'll ask is, was there chondral injury at the time of the fracture? So I think for these patients, we're kind of obligated to scope them. And I, in my practice, if they are displaced to the degree that you have to reduce it, I will perform a quick ankle scope. Dr. Guyton did this paper just looking at when you know the syndesmosis, when you know the syndesmosis is disrupted, and this little 3 millimeter probe of diastasis confirms that. But I think scope is the gold standard to look at this. And I also love it to look at the deltoid. I really like Chris's talk, but the deltoid, if you see the posterior tib through that scope, the deltoid is obviously completely torn. Here's a great kinematic study, biomechanical study, and there's a lot of things on the slide, but what you can see from this is that when you do flexible fixation, even with 2 tight ropes, you don't really restore the external rotation. And I believe it's because we're, again, not addressing the deltoid. And so 2 tight ropes do not control external rotation. Here's another great study, Shoji et al. In clinical biomechanics. They found that the screw is obviously more stable than flexible fixation. And they found the closest to the intact state was the suture button plus the anterior AITFL augment. But it actually was not statistically different than just doing the AITFL. And so in this study, again, the deltoid was cut but not repaired. And so I've been doing this for a lot of my athletes for their syndesmotic reconstructions, especially when the posterior ligaments are intact. I put a suture anchor into the fibula. I dock it into the foot tubercle of the tibia. And my thinking is if that the PITFL is intact, much like an APC pelvis injury, you can block external rotation by just closing down this front space here. And that technique I've probably done at this point maybe 50 times in our elite athletes in that population. So to fix the deltoid, I think at Duke, they published this study, 15 with transsyndesmotic fixation, 12 where they fixed the deltoid. They found no statistically significant difference between the 2 groups. And their theory was perhaps deltoid repair is equivalent to syndesmotic screw. But what I ask is, when we do these stress tests, we do this external rotation stress test, and obviously the medial clear space is the easiest thing for us to measure, right? There's less variability, but I wonder, are we really looking at a syndesmotic injury, or are we confirming that the deltoid is injured? Harper et al., published this paper in Core in '88, and I would argue this is the paper that led to a lot of our partners and even ourselves not fixing the deltoid. They looked at 36 patients, not a huge study. They fixed the fibula, 15 of them got syndesmotic fixation. And they just said 28 had good outcomes, 4 had fair, and 4 had poor. None had valgus tilt on stress testing. None had medial instability or asymmetric valgus. But if you read the study, 22% had loss of reduction, whatever that means. But if you look at this picture on the upper right, you can see that they fixed the Weber C fracture with a single screw. And already I would argue there's some joint space narrowing. This is one of the explorations that I did earlier on in my practice. You can see this complete avulsion of the deltoid. Here's a closer up look. You can see the posterior tib just inferior there. Rosa et al., this is one of my favorite studies to quote, but they found, looking at ultrasound and stress testing, that if you had a complete tear, you'd get 5.8 millimeters of medial clear space on stress testing. And so in my practice, on any view, if you have more than 6 millimeters of medial clear space, I'm exploring at least the deltoid. And so far, I've not found a deltoid that's intact in probably 30 or 40 of these that I've had to do. I don't clamp or tie the sutures until after I fix the fibula, as Chris discussed with his percutaneous technique. I think you want to fix the fibula so you can tension the deltoid appropriately. And here's what that repair looks like with those 2 suture anchors. Our colleague and my mentor, Dr. Anderson, published this paper in the NFL, and he, for that exact fracture pattern, all the patients underwent scope, fibular ORIF, flexible fixation of the syndesmosis, and deltoid reconstruction. 86% of the 14 players all returned to running and cutting by 6 months post-op, and none had medial pain or instability. He followed them up to 2 years. You can see a very similar picture as the one I just showed you from that paper. So for this gentleman, the plan was to do a scope, fix the fibula anatomically, reconstruct or repair the deltoid, fix the syndesmosis. I was going to use a direct repair and then a tightrope if needed. Here's his scope pictures. Luckily, there's just some synovitis, minimal scuffing in the back of the ankle, but otherwise looked great. And here's the approach to the deltoid. Again, very consistent. Everyone I've seen so far that I've explored with more than 6 millimeters of clear space, here's what that looks like. We fixed his fibula anatomically. I do like this metadiaphyseal plate. I think in these football players, who are quite big, you can put a plate, and at this level, there's no real concern for soft tissue irritation. So this is a sort of a 1/3 tubular, an LCDC combo plate. Fix the deltoid with 2 suture anchors. Versus syndesmosis, I try to close down the space with circumferential reduction, either with an S mark, or lately I've been using a very thick kind of Penrose drain to go around. And as I showed before, I dock it into the Chaput tubercle. And in this case, I used 2 suture tape to go from the distal 2 holes and docked it. And then I stressed it, and he maintained anatomic reduction. Here's what that looks like on the lateral. And so this patient, here's his post-op x-ray. I would argue good tib-fib overlap, anatomic reduction of the fibula. And here he was at 6 months post-op. He did very well. My post-op protocol was 6 weeks non-weight bearing. I put him in a splint for 2 weeks. I did cast him for 2 weeks, just given his ligamentous injuries. He returned to running and cutting by 4.5 months, which was non-contact. And he did miss the combines, but he's cleared for full football activity at 6 months. And he was drafted in the 5th round, which his draft status kind of fell significantly after this injury. And he returned to play 10 months post-op. And he completed his 2nd season in the NFL, and he's actually this team's #1 cornerback. So for me, I think these things, I'm going to go through this briefly, but I think the syndesmosis and deltoid are evolving. The tightrope may not control external rotation. You should fix the deltoid in that instance. And the syndesmosis may be analogous to the APC pelvic injury. Again, 6 millimeters, I would strongly recommend exploring and repairing the deltoid. And if the fibula is broken, it must be fixed anatomically. A scope any athlete in a displaced fracture, and return to play anywhere from 6 to 12 months. Protect your patients, let them heal appropriately, and don't let other people dictate their post-op course. And finally, football is a very violent sport.
Great case. Thank you.
Of course.
So we have about 5 minutes here, and there's obviously a lot we could talk about. But one thing that I'm really interested about. So Joe, maybe you can start your thoughts on this, and if anyone else in the group has input. So the order of things.
Yeah.
So say you have a fibula fracture, your deltoid is out, and your syndesmosis is out. Right. And I think in most cases, most of us would fix the fibula first. But tell me about your order from there on.
Yeah. So actually, that's a great question. So actually, first I'll explore medial. So if my threshold is 6 millimeters, I'll actually make the approach medially first. Just given my experience and with the very good literature that supports it, I will put in my 2 anchors, either 1 or 2 anchors. I'll grab that medial tissue, and it's pretty amazing when you pull on that big sleeve of the deltoid. It helps you with your reduction, and it also, many times it's interposed, and I argue it blocks your fibular reduction somewhat, getting the mortise reduced. So I will not tie it, but then I'll go back and fix the fibula. Then I will tie the deltoid and then do my syndesmotic stress testing. and do either a direct repair or you can use a screw. You wrote a good paper looking at length unstable fractures, and that flexible fixation may not be the best choice. And I agree with that. I think if you have a very comminuted fibula, I'm very hesitant to use flexible fixation, and I'll often use a screw and flexible fixation. But I would love to hear what the other guys think too.
It's funny. It's funny when you mention, because I was thinking that same question, because I do it a little differently. I'll fix the fibula first. Then if there's an unstable syndesmosis, I'll fix the syndesmosis. And then what I've started doing is an external rotation stress test. And what I find is that the majority of patients in whom you fix the syndesmosis, the reverse happens, right? Just like we showed in some of our studies that the deltoid contributes to syndesmotic instability, the converse can also be true, especially if you're using rigid fixation like screws. And so, I externally rotate them, and then if they open, I'll fix the deltoid. And when you think about it, I think there's a lot of controversy about fixing the deltoid, and we should be specific, the superficial deltoid. We're not fixing the deep deltoid.
Correct.
But when you think about your practice, how many ankle fractures have you had to revise because the deltoid wasn't fixed versus how many have you had to revise in your practice because the syndesmosis wasn't fixed? And that's where I think we're converging on the same point. But that's why I tweaked the order, but it's a very interesting presentation. So thank you.
Yeah, Dan, that's a great point. You're right. If you put a screw first before you stress the deltoid, you will find that the medial clear space doesn't open up. But I think, it's hard for me, having seen so many of these avulsed deltoids, to feel comfortable leaving it unfixed now. Because you're right, if you put a rigid fixation, it will not open up. But I know that that's off as a sleeve. And to answer your question about going back, I've had to revise many people's fractures whose deltoids have not been fixed. They'll get delayed valgus, like the case you talked about. You'll have a subtle injury, but over time it will stretch out. And I've had to go back in and reef that later.
And was that because of a deltoid wasn't fixed, or because of a fibular malreduction or a syndesmotic? You know what I mean? That's the reality.
Yes. I think it's a little bit of all of those, right? If you fix the fibula perfectly, your chances of getting away with it is way better. And if you fix the fibula poorly, the chances they tilt into valgus is astronomically higher, or leaving it non-op like you showed.
All right, John, that's an excellent end to this awesome session. We appreciate everybody's expertise and pearls. Great talks, guys. We'll be back in a few moments.
All right.
Thanks.
Thank you, Selene.
Thank you.
Thank you, guys.